Hi, everyone. Thank you for joining us today for our webinar on cholera. My name is Meline Alexanian. I am the program administrator at the Center for Emerging Pathogens at the University of Southern California. We work with national and international organizations providing guidance in all areas of infectious disease. So far we have collaborated with over 90 organizations. We work with them to increase awareness for the populations they serve and to provide advisory services for infectious diseases like yellow fever, cholera, and of course, COVID of late, which has taken center stage globally, as we all know. So in one of our collaborations has been with Public Health Aid Awareness Organization and Education. Public Health Aid Awareness and Education Organization in Nigeria. And we have been working with them to organize this webinar about cholera at a time when there is pretty large outbreak, largest in recent years. So I'd like to introduce Uchechi Okonmo, who is the founder of the organization, FEI. She will tell us a little bit about their efforts.
Yeah, thanks, Melin. Thank you, everyone, for joining in. My name is Uche Okonma. Yeah, I'm the founder of Public Health Aid Awareness and Education Organization. Organization focused on women, adolescent girls, children, and in marginalized communities. And the area of our work is on water, sanitation, and hygiene. With the outbreak of cholera in these recent times, I felt that it was a necessity to have this webinar for everyone, not just for, at some point we had to streamline to like school owners, head of organizations, institutions, primary healthcare workers, but a second thought, you found out that it was for everyone. So thank you, Melly, for this opportunity. I will say more than thank you.
Thank you. No, it's been a great collaboration so far, and we're looking forward to doing more of these webinars with FEI. So I'd like to introduce our founding director of CEP, Dr. Nehananda. She is also associate professor at the University of Southern California. Dr. Nanda?
Thank you, Mel. Good morning, everyone. Good afternoon, everyone. It's good afternoon in some of your worlds. Thank you so much, Uchechi, for this collaboration. And thank you, everyone, for joining us this afternoon. What I'd like to do, and I want this to be a dialogue more than a monologue. I'll start with sharing with you a little bit of, actually, Mel, is my audio okay? Let me.
Yes.
Okay. What I'd like to do is I'll start with a little bit of history of cholera and the lessons we've learned in the past pandemics. I think there's so much that we can learn from the history. And then I'll touch on clinical scenarios and then go deep into the preventive strategies. Because I mean, you people are well aware of the situation in where you are, and I hope we are able to help you with some pointers. And then we'll open it to Q&A. So with that, you know, it's interesting that cholera was first described in the 4th and 5th BC in some Indian and Greek texts, where they said there was some kind of diarrheal illness, but they didn't quite name it. Then in the 1500s, the Portuguese said, you know, in the Ganges Delta in India, they had people dying within 8 hours of symptoms. And they were, again, symptoms of diarrhea, and they had people just dying. So that was the first time that it was actually identified as a disease, so to speak. Since then, as you know, we have had 7 pandemics. Currently, we are in the 7th pandemic, which started in 1961, as you see on the slide. And the difference between the current pandemic and the previous pandemics is that the bacterial strain, the type of bacteria, it's all caused by Vibrio cholerae. The strain that is causing this pandemic is more hardy. By that, I mean it can survive longer in food. It can survive longer in brackish waters. So it makes it a little more challenging, and that's where preventive strategies come in to help in fighting the pandemic. So, and another thing that's interesting is that the previous pandemics, many of them started in India. The current pandemic started in Indonesia. And as you can see on the map, the areas that are marked are areas where there is the highest incidence globally. And if you look at global numbers, you may be well aware on the numbers of cases vary anywhere from 1.3 to 4 million a year, with about 21 to 43,000 deaths. Now, if you look at the numbers in Nigeria, where there's so much happening around the pandemic with all the preventive strategies, given the burden of disease, you can see there are about 93,000 cases with a case fatality rate of 3.5%, which is huge, and more than 85% of your states, more so in the northern part of the country, have been specially hit just because of the flooding, which results in increased transmission. So, we are talking about the past really so we can learn more about how we can deploy preventive strategies. And one thing that we have learned from other pandemics and this pandemic is that we have to focus on treatment and prevention simultaneously during an epidemic or a pandemic. And now if you break it up into buckets, one of the biggest things we have to focus on is multi-sectoral planning. Mel, if you want to go to the next slide. Yeah, so what you see here is on the right-hand panel, you see the multi-sectoral interventions that can be in place that can be in place to prevent pandemics. And this is all based on the lessons learned from the past. So when you talk about a multi-sectoral planning, we talk about having resources for surveillance. And when I talk about resources, we are talking about diagnostics. We need rapid diagnostics. We need laboratory-based culture diagnostics, which is not easily accessible. But as you can imagine, it is so important. If the first patient I see and I'm able to confirm a diagnosis, thereafter subsequent cases that have similar clinical symptoms, based on a very high pretest probability, I would know it's cholera, and I would even deploy preventive strategies. When you talk about preventive strategies, I think vaccination becomes very important. And with that, we know there is scarcity of vaccination still in so many parts of the world, including from what I understand from Uchechi, even in some parts of Nigeria. But it is so important to have oral cholera vaccine available in endemic area, and especially in the setting of outbreak. And I say this is based on lessons learned, because clearly they did this in southern Sudan, where they had a lot of refugees, and preemptively they gave vaccination. And they knew their population was malnourished, and they were able to reduce morbidity tremendously. The number of cases reduced. There was a similar story even in Malawi and in Yemen. If you see, when you talk about vaccination, they had a lot of cases because vaccine arrived 16 months later. But at the same time, what they had done is they had a multi-sectoral approach where they focused on the infrastructure and they focused on management and preventive strategies. The vaccine was not something they were able to avail of earlier on in the pandemic. So with the lessons learned, what I'd like to do is I'd like to pivot to, actually, before I do that, I want to just touch on the Global Task Force on Cholera Control, their roadmap. So this was established in 1992, actually, and it takes into account a lot of the lessons that we just talked about. They talk about focusing on preventive strategies. That's the WASH strategies that Ucheche is working on, then oral cholera vaccine and early diagnosis, and also collaboration and sharing resources. And I think FAE and CEP here at USC is a perfect example of the collaboration that is happening at a global level that has been supported by the Global Task Force of Cholera Control. And as you may know, according to their roadmap, and I hope we are able to achieve that, that by 2030, we will be able to reduce the deaths associated with cholera to 90%, by 90%. And we will be able to eliminate cholera in 20 countries. They focus on around 47 countries. And they want to be able to focus on eliminating it in 20 countries, at least by 2030. With that, I'll pivot to talking a little bit about clinical presentation. So as you know, that there is a huge burden of asymptomatic disease. 60 to 70% of the people are asymptomatic carriers, and they can transmit disease. And the group that is symptomatic starts with typically diarrheal illnesses. So severe diarrhea, you lose a lot of water, and you want to prevent the person from going into the dehydrated state. Less than 5%, as some of you must have seen, present without diarrhea. It's very rare. And they'll just present with abdominal pain. It's typically the highest incidence, it's in the younger age group, 5 to 14, even infants for that matter, and sometimes even in the 20s, as Ucheche was sharing with us. For severe dehydration, obviously patients need to be hospitalized and they need to get fluids, Ringer's lactate if it's available in the initial phases, and then quickly transition them to the maintenance phase where we rely on oral rehydration solution to replete the electrolytes. And obviously, because we want to maintain our healthcare capacity, there are good criteria and reliable criteria, but there are clinical criteria which decide if it's okay for the patient to be discharged. And as you know, you want to make sure that the urine output is good. The person is able to hold water, and the insensible losses have dramatically stopped before the person is discharged. And when we think about treatment along with fluids for severe dehydration, there is data, as you know, if you were to give antibiotics to them, to the patients, we are able to reduce the duration of illness by 50%. And the commonly used drugs in different parts of the world are different. But you want to rely on the susceptibility data, the antimicrobial susceptibility data in your area. So some of the drugs are tetracycline, doxycycline, azithromycin, quinolones, and Bactrim. The advantage of doxycycline and azithromycin is that it's a single dose drug, so you don't have the logistical challenge. And also keep in mind, we are not able to give doxycycline to children for obvious reasons. And in pregnancy, we prefer giving azithromycin, that's a single dose. And then I'll move to just touch a little bit on diagnosis. Different areas have different resources, but diagnostics is very important when you talk about surveillance, when you talk about immediate attention to prevent morbidity. And there's a rapid diagnostic test. Then there is a culture that can be done. And like I said, different places have access to different kind of modalities. And I think it's a good time to now talk a little bit about vaccines that we rely on. So currently what's available is the oral attenuated oral cholera vaccine. And the good news is that more than 2 years of age can get the vaccine. Some of the vaccines even more than 1 year of age. And based on some studies that have been done, it's safe to give in pregnant people. And it's really important in pregnancy because, as you know, it's a very severe disease in pregnancy. It can result in 50% fetal loss in 50% of the cases. As high as 50% of the cases can have a fetal loss. So it's really important to give it during pregnancy. Even it's been approved and it's been blessed by the WHO to give it during breastfeeding. The challenge with vaccines is that we cannot give them in infants, where again, the morbidity is high, and also access to it. And also it doesn't offer lifelong immunity. You have to give it every 2 to 5 years again. There are vaccines that are live attenuated that are still in trials. They're not available anywhere outside the US. So I think there's more research that needs to be done in cholera vaccines. And there's research and also, I think, access to vaccines, because if you're able to vaccinate a community when it's endemic, you will obviously be able to, we will obviously be able to avert a pandemic or an epidemic. With that, let's talk a little bit about transmission and then get into prevention. So I think we all know it's transmitted through water and through food. When it's transmitted through water, the amount of bacteria required is much higher. So to give you a sense, the amount of bacteria, the colony forming units required in transmission through water is about 1,000 to, I would say, 100,000 colony forming units. And it's about 10 times or 100 times more, less when it's transmitted through food. Know that it's pretty hardy. It can live on surfaces for up to 14 days. And typically a person who's acutely ill is the person who poses the highest risk, especially to his household members. We talk so much about climate change, and it's interesting that seasonality and climate change also weighs in when you think about cholera. So it's a well-known fact that wherever there are more hot seasons, there is more proliferation of Vibrio cholera, thereby more disease. And also, we talk about climate change. There's this phenomenon known as ENSO, that's ENSO, and the full form is El Nino Southern Oscillation. And this is basically, it's a phenomenon which represents the global variability of that may affect the incidence of certain infectious diseases. And the way it and the way it pertains to cholera is, what happens is that ENSO causes warming of the Pacific coastline waters. And this was actually seen in Peru. When there's warming of the waters, there is growth of plankton. There's a lot of plants and animals that proliferate. When that happens, there's a lot of Vibrio that proliferates. And what we have also learned over the years is it's not only proliferation of the bacteria, but the kind of bacteria that proliferates is more virulent. It's more dangerous, as in causes more severe disease. So again, a compelling reason for us to focus on preventive strategies as it relates to climate change, especially as has been exemplified by ENSO in Peru. With that, let's talk about preventive strategies. So definitely climate change is something that we keep in mind, and the biggest and the mainstay is safe water. And as you know, there are so many initiatives around WASH, which nicely exemplifies water and sanitation, safe water. So you all may know this, and all of this information is from CDC, WHO, and from experience, that we want to make sure we are able to make our water safe. And how do we go about doing that? Either we boil the water. If it's not a very high altitude, we can do it for 1 minute. If it's a high altitude, you want to boil it for longer. And if you don't have access to boiling the water, we can use chlorine tablets. If we don't have access to boiling water or access to chlorine tablets, then we can use household bleach as a disinfectant. Depending on the concentration of bleach, you take that amount in water. If it's a lower concentration, you want to obviously use more of the bleach. So for instance, typically in several parts of the world, it's 5 to 9% of household bleach. And if you have if you have a gallon of water, you want to use 0.5 ml of household bleach. If you have a liter of water, 0.1 ml of bleach. And if you have 5 gallons of water, it's 2.5 ml. By the way, we'll send you the slides later so you don't have to take notes here. And we can even send you some links. So going back to the disinfection of water. So these are some strategies. And after we have decontaminated or made the water safe, storing is another piece that you want to be very diligent about. So you want to store it in containers that have been disinfected, again, with some form of disinfectant, whether it's bleach. You want to make sure it's been air dried. And the water that is stored, it's imperative that we use it for 6 months, and after that we discard it, because that's the shelf life of the safe water. Also, when we store water, we want to make sure it's in containers that have a narrow neck, so contamination is at its minimal. So that's about safe water, and then we talk about safe defecation. And safe defecation, obviously, as you know, we want to make sure if toilets are not available, the fecal excreta is far away from water where there's access, which will then be used as safe water after it's been cleaned. So typically we recommend it should be at a 30 meters distance wherever there is fecal excreta. And you want to be 30 meters away from any body of water. And the way to actually make temporary pit toilets is to have at least about a 1.5 feet depth. And you can keep rotating these areas so that the fecal defecation burden is at its minimal. And of course, here on the slide, we talk about personal hygiene, where washing hands, it's simple. We've said it, we've taught it to even students and children, but I think some simple things, some pointers go a long way. You want to make sure, if possible, it's running water. If it's not running water, make sure you are doing a good job while washing your hands. You're getting into the nooks and crannies. We teach students to sing happy birthday for the 20 seconds and then scrub hard so you can actually get rid of the impurities and the bacteria. And in fact, I remember going to my daughter's school and doing an experiment with them and showing on screen with a microscope as to, even after the kids wash their hands, how much of dirt is still there. So, we put some cream on their hands and then they had to show whether they actually cleaned it well or not. So it took them around 4 or 5 times before they were actually able to get it clean. It was a nice lesson. They kind of learned that you have to really do a good job. And I'd be amiss if I don't touch on food hygiene, which is so important. Boiling the food, peeling it well. And always we say that it's better that you have fruits that have a cover so that we can prevent any kind of contamination or cross-contamination. And of course, household hygiene. If you have someone who's infected, you want to make sure you're cleaning surfaces. You want to make sure the person has a separate toilet, if at all possible, as you're trying to prevent any kind of transmission within the household. So you know what, I will stop with that because I don't want this to be a monologue, and I hope this information, the tidbits that I shared with you, are helpful. And I'd love to have a conversation or answer any questions.
All right, if anybody wants to ask questions, feel free to unmute, or you can type your question in the chat and I will read it aloud for Dr. Nanda. We did have one submission in advance. So this person asked, knowing that cholera is asymptomatic, how do we prevent cholera as an emerging pathogen? What strategies and policy intervention can be put in place so we avoid infected persons getting to a collapse stage of the infection and also prevent it from occurring in the first place?
Yeah, so I think that's an excellent question. Let's break it up because it touches on so many things. So the disease, I think, as we alluded to, in up to 20 to 30%, you will have symptoms. The remainder are asymptomatic. Our suspicion for asymptomatic disease should go up when you see cases in the community. Now, the way to prevent that is, I know we don't always have the luxury to do that, is when there is an epidemic going on, you want to make sure everybody's using a dedicated toilet, which is not really possible, even in a household. But what we can do is we can focus on all the preventive strategies, as in we wash our hands really well, we decontaminate toilets, the surfaces after every use, and we be very good about handling our food during this time. Now, if someone is symptomatic, if possible, that person should have a dedicated toilet, or even if they are, using an outdoor setting, as in when there is open defecation, you want that person to go outside. These are a couple of strategies at a grassroots level. When you talk about policy, I think a lot of it is the lessons that we have leaned on from previous pandemics. We want to rely on oral cholera vaccine without a doubt. We want to emphasize a collaboration at a community level. And when I talk about a collaboration at a community level, I'm talking about educational campaigns. I am talking about conversations like this. This is the time that you want to be able to talk and discuss what's happening in your world, and we share with you what's happening in our world and what we think. So a lot of it is campaigning, visual posters, maybe having, PSAs to talk about cholera. So that's education. At the same time, having resources available for rapid testing and have access to antibiotics, which is a second line therapy when there's severe disease. So I could keep going on and on, but the point is that it has to be a collaborative effort when you think about community policies. Mel, I'll stop there.
Yeah, another question. Are there certain...
There is someone is raising their hand. Please unmute yourself and please ask your question.
Yeah, thank you so very much for my name is Bolut Feoluadele. I actually live in Canada, but I grew up in the 60s, 70s, and I still have a vivid memory of what cholera did to so many communities when we were growing up. Your solutions are very visible, they are very practical, and I've seen some of those suggestions applied. But as my concern today is like many households are now living below the poverty level. Most of these solutions, they could not afford them. Yes, washing hands is good, but what if the water itself is already contaminated? So when you wash your hand with contaminated water, and public water system is not in good shape in most of these communities. Some don't even have, and few people that are able to, people of goodwill, have been able to sink some borehole in some places, which oftentimes, when they are not well maintained, they collapse. So when you have people like that who will go back to, untreated water, what kind of practical solution can we give to those? Because all these solutions that we have suggested may not be workable because they don't have the means and to apply those. They can't afford chloroquine, chlorine, for instance. They can't afford bleach, and their lifestyle is, there was one horrible day they used to say that water doesn't kill. In those days, cholera came and became very devastating, and there are people who still held on to that idea that no matter how terrible the water is, it cannot kill you. But that is far from the truth. So apart from education, what can we do practically to help communities that are living far, far below poverty level? Thank you.
This is an excellent question. And, can I ask you, I totally understand, and I myself, my training part of my training was in India, in villages, where it's very unfortunate to see children die of cholera, within hours of their arriving to the hospital because they arrived so late. And then when you go to those villages, part of our internship as a part of our training used to be in villages where they did not have access to bleach. They did not have access to tablets that we are talking about here. So what strategies we came up with, and please tell me if this is a possibility in the areas we are talking about. Is it possible to boil the water?
Yeah, it is possible to boil the water, especially again, but there's another challenge here because we talk of environmental concern now. The cost of kerosene, the cost of gas is beyond the reach of the poor. So they have to rely on firewood, go to the bush to cut down firewood. Again, there are some campaign against that by the environmentalists because they are decimating the ecosystem as well. So it's like that situation is very complicated. Then I remember also there was this idea of using white cloth to filter water.
Yeah.
Maybe for those ones, if you can supply, if people can supply clean white sheets and
yeah,
for filtering,
so, yeah,
that may work more because most of them who will depend on kerosene to boil water, gas to boil water, they will want to go to that route. I even spoke to somebody recently who complained of typhoid, and I said, okay, why don't you boil your water? And they said, oh, do you know the cost of gas in Nigeria now? You ask me to be boiling water. I said, but it's for your head. So, yes. But anyway, when you talk of poverty and it makes some knowledge to be, to look like a child's play, because to them, what you are telling them doesn't speak to their reality. So what kind of intervention we can give to those people? Because understanding their situation that they find themselves in a very extreme poverty, and when you say all this to them, it doesn't make sense to them. But I know that
one of the things that has worked is we used to say, so in India, there's this cloth that women wear called a sari, S-A-R-I. It's basically a cotton cloth, okay? And when we are talking about poverty and you want to have good water, when the water is dirty, which most of the time it is, you have the water flow through the sari, that's the cotton cloth, such that the impurities are held there, and the water that you have, you drink that. Now, when you don't have any water and you don't have the safest water as a result of boiling or tablets or bleach, but you need water, otherwise when someone's dehydrated, what are you going to do? I think that is one strategy, that you take the water and you kind of clean it with that cloth such that you get rid of the impurities. I know this is not easy, but I think some of these solutions can work, and it starts with education. And we can say what we want, but the person who's in that house or in the village knows best what else they can utilize. That's where education and understanding the options they have and what is the best option in the options they have is also very helpful. There are some hands raised. Mel, go ahead.
Yes, Tukur, would you like to go ahead?
Yeah, thank you very much for this very wonderful opportunity. Immediately I saw the topic, I felt is high time, and I should also lend my voice on it because of how important it is to us generally. I have a couple of questions, and then I have comments, especially regarding the challenge that was presented right now. The fact that majority of victims of this cholera are below the poverty line, and then the strategies being presented are sometimes not affordable. We work with other partners that help us to provide what they call aqua taps. Aqua taps are actually made of the hypochlorite solutions that are made in form of tablets. So when we have areas that are affected with it, we distribute it to them and they use it to disinfect their water. In terms of the comment I wanted to make was that when you made mention of intersectoral collaboration in the prevention of cholera, the first thing that came into my mind was to hear you talking about the various sectors that should come in control and prevention of cholera. In most places, they consider it as, because it has a health background or a health shut up, all the concerns and support are mainly from the facilities or health workers. But cholera prevention is beyond that. It has an aspect that has to do with environmental control and sanitation. It has to do with wash, water hygiene and sanitation. It has to do with even security, because right now, majority of our cases came where there is security in compromised areas. So you see that security personnel has a role to play in ensuring that access to inaccessible areas because of lack of potable drinking water and other security related issues can be. Hello?
Yeah, go ahead, please.
Oh, okay. So that is the aspect of the multi-sectoral collaboration. But the question, what remained tantalizingly obscured to me is about the pathogen, the Vibrio cholerae. Why is it that it remains so persistent over a very long time? Yeah, you're talking about since 1960s or even 15, a very long time. And you find out that it runs throughout the year, only that the cases does not cause an epidemics unless when it's very much. So what are the Nikes? What are the factors that support its viability over a very long time? Yeah, it's not interrupted. So that's maybe what I'm interested on, the
This
pathogen.
is very interesting. Thank you.
Thank you very much
for this,
yes.
for these comments. And I love this conversation. This is true infectious disease we are talking about.
Yes.
And I'll tell you, so, you know, any infectious disease where you have asymptomatic carriage, as much as you have with cholera, here we are talking more than half of the people who are infected are asymptomatic. Once you have that, what you're capturing is only tip of the iceberg. And it's just difficult to get to the bottom, to the remainder of the iceberg. And that is one of the strengths or one of the attributes of Vibrio cholerae that makes it keep going on and persistent. And that's why you have 7 pandemics. And, you know, it's going to keep going on and on till. Now, let's talk about what our true north is. By the way, this is amazing. I am so excited as an ID physician and an epidemiologist talking about this. This is amazing. So what is it that'll help us avert or abruptly end a pandemic? Let's imagine there is a small community, okay, where we have, let's just imagine a true north where we had resources available. So what would we do? What we would do is we have diagnosed a case of cholera. What we would then do is in that small community, we would do asymptomatic testing. We would test everybody who is in that community to be able to identify. Once you have identified, let's think about what you would do then to contain the disease, we would isolate or quarantine that person. And if we are able to do that, we are going to prevent any kind of transmission. At the same time, in the background, if you have aggressive cholera vaccine going on, campaigning, that would be amazing. I know it's not available today. Let's say the true north, at some point, we will have a vaccine that we can even give the infants, or we will have a vaccine and the vaccine will have a longer duration of immunity that it imparts to us. If everybody is vaccinated, let's say every 5 years, every 3 years, depending on how long the immunity lasts, that's when we'll be able to get to it. But it continues to be a challenge simply for the reason that I stated. There's this huge carrier state, which is not always diagnosed. In addition to that, we know that this bacteria can survive for so long on inanimate surfaces that are not even living. It tells you it's very hardy. And that's where preventive strategies like cleaning surfaces comes in. So, just a simple thing that we've always followed is after someone has used the restroom, you want to clean the surfaces. If you have access to products like household bleach and water, it's 1:9. If you do that, then you can prevent further transmission. But I think these are some of the things, Tukur, that I can think of that why this is happening. It's because of the huge carrier state, and also in the absence of effective vaccines and also lack of accessibility. And when we have the resources of testing everyone, once a case is identified, in that kind of a scenario, we can actually think about aborting or averting any additional morbidity. Tukur, does that answer something?
Excellent. Thank you very much. Quite excellent.
Thank you for bringing this question up. You made my day. You made my weekend, actually.
Thank you very much. Thank you.
Thank you. Shabana, you have a question?
Yeah, I do. You mentioned about the SARI just now, right? So
Yeah.
how does using the SARI actually prevent the pathogens, or like by filtering them? What is the mechanism of that?
Shobhana, I see your name, so I'm guessing there's Indian ancestry somewhere similar to mine. So with SARIs, the intent is, by the way, the SARI, for everybody, it's, yeah, I don't have anything around my house right now. I can't show it to you, but it's basically a very thin cloth that allows for all the impurities. So sometimes water is so dirty that there's actually sediment there, there's silt, there's mud. So that gets captured, Shobhana, in the SARI, and the water flows through. It's basically a filtering technique where you're reducing the impurities in the absence of having access to electricity or other measures to decontaminate the water.
But wouldn't a few of those bacterium pass through anyhow? Or would it just actually get filtered because the SARI actually functions like a filter paper, right?
Yeah, exactly.
But wouldn't a little bit also go through?
So a little bit will, and we are talking about a scenario where nothing is accessible. So, it's not the safest option, but if you don't have anything and you need water for a sick person, what are we going to do? One other thing we could do is that one thing I should mention, when we use SARIs or we use cloth, we can use cloth with different thickness, starting from thickest to thinner, and then also allow the water to stand for a long time. Once you let the water stand, the sediment, again, the remainder of the sediment will settle at the bottom. So it's going to be a combination of multiple times filtering, multiple times making it stand. That's when you will be able to reduce it. Having said that, this is in no way going to be 100% decontamination. Definitely, I acknowledge your comment, Shobhana. It's not going to be anywhere close to the level of purity you would get or the safety that you would achieve by boiling.
Okay, thank you so much.
Thank you. Does anyone else have a question?
Can I ask?
Yes, go ahead.
Okay, Dr. Nanda, I just want to ask, because we come from Malaysia, so I don't think we have this cholera vaccine as y'all are using it there in Africa. So what is the dosage that y'all give, and how do you actually give it to the patients? And is it free?
So I can tell you a little bit about the vaccine. The vaccine, so there are 3 vaccines that are available typically. It's Dukoral, Shankol, and Uvicol. They are available and there are 2 doses, typically given 7 to 14 days apart. And it needs to be stored anywhere from 2 degrees to 8 degrees. And you're right, it's not available everywhere. I don't know in Nigeria if it's free of charge, but maybe Uchechi can tell us that. But this vaccine in some parts of the world where it's available, I know it's available free. It's given, it's an oral vaccine. So you don't have to inject it. And for obvious reasons, you want it to be oral because we need the immunity in our gut. Uchechi, is it free? In some parts of Nigeria?
Yes, it's free.
Sorry,
actually.
I didn't get that.
It's free,
Okay.
It's actually free. We use Sahol.
Okay.
The Sahol, like you rightly said, we give it at the interval of 7 days.
Okay.
And when we did it, because it was not readily available, we targeted children between 10 years and above. So we gave it on 2 doses.
Okay.
And yeah, it was given free, but it was actually a support from UNICEF. So, sometimes you see something is free, somebody paid for it. Actually, it was UNICEF that supported us with the vaccine. And right now, I think in the next 2 weeks, we are also going to pilot another vaccination with the oral cholera vaccine.
Got it.
Of our LGs.
Got it. So also, I think to add to what you said, I believe the Global Task Force on Cholera Control, they started a stockpile of oral cholera vaccine in 2013. So they should be able to deploy it. I know some countries where they've deployed it and it's free of charge. Nalini, does this answer your question?
It does. Just one more thing. Can I ask you one additional question? If it's given only from 10 and above, what about the kids below 10? Are y'all also targeting them?
So, I know that Dukoral can be given to children as young as 2 years. And I want to know from Tukur, why are we doing more than 10 years? Because it is, I believe, safe to give it 1 year and over, but I'm sure he knows why.
Exactly. Yeah. You know why we did it like that was that when we look at our statistics, we found out that the age range that is being affected was around 10 to 14 years, were the mostly affected, and then some extreme ages. And then the vaccine was not much, so we have to strategize and give the most vulnerable in terms of the affectation. Based on the indices that we had at hand. When we analyzed, we found out that those are the ages that are mostly affected by the cholera cases. So we prioritize them because the vaccine cannot go round all to cover everybody for the 2 doses. And the efficacy of the vaccine is higher when you give the 2 doses within that interval. So the amount was not much to cover the entire population. That's why we have to prioritize and now give those numbers. But we can actually give ages below 10, like you rightly said, 2 years and above. But then there's what guides our decision. Thank you.
So you had to risk prioritize based on IC. If you had excess, Nalini, I mean, they would give it to everyone like it's licensed, but it's just risk prioritization.
I can understand. I know resources are very, very important there. Thank you so much for the clarification.
Mel, there's a question by
Oh, go ahead.
Anabulu. Please go ahead.
Okay, good afternoon. Thank you so much for the very informative presentation. Just a quick one. What would you say would be the most critical preventive and treatment strategy when you are considering an emergency or displaced situation? You know, you've talked a lot about the community situation, but in a refugee camp and that kind of displaced community, how would you translate some of these measures, and what will be the critical difference?
This is really a very good question, because I think we are talking about risk prioritization at its best. And I think the one thing in that setting, I'll imagine a pyramid, and what's on top is safe water. That's it. And let's go now bottom, now the next year would be access to oral cholera vaccine. But really water, and in fact, nutrition, because in the refugee camp, I'm going to assume similar to what we've seen in the past, there's a lot of malnutrition. It's food and water being safe, potable water right on top, without a doubt.
Great, thanks. Thanks a lot.
We have a question in the chat. Excuse me. Someone asking about the access to vaccines for vulnerable children, as this is one of the challenges that we are facing in various communities as a community-based organization that deals with abandoned and vulnerable children. Most times we are told these vaccines are not available. So if anybody has any insight into this in Nigeria.
I think people who are on the front lines in Nigeria, or anybody who has a role in the policy, if they can weigh in, if we have anyone, that would be great.
Yeah, vaccines are being given through the National Primary Health Care Development Agency, and in collaboration with CDC, that is Center for Disease Control. On regular basis or on daily basis, cases of notifiable diseases are being reported from the facility level to state level and to national level. So it's been analyzed, and then decisions are being taken on where to deploy such vaccines, not only cholera vaccines. There are all sort of vaccine preventable diseases that are being taken care of. So I'm sure if that community is within the Nigerian settings, I'm very sure if we could just look at our SOMAS report, we find out that the rate is there. I am sure the National Primary Health Care will certainly work with CDC to get vaccines to deploy to that area. There was nothing special to be done. This the responsibility of the national body, as the National Primary Health Care and the Center for Disease Control. They're on top of the surveillance activities. So, over.
Okay, thank you, Tukur. That's really helpful.
If we don't have any other questions.
Well, there's a question I just saw. Will you recommend solar disinfection in camps for displaced people, considering the risk associated with it? Elizabeth, if you're on, if you can speak to it, are you talking about solar disinfection of surfaces, water? What are you referring to? It's a good strategy, but relying on it alone for anything, especially water, can be challenging. Elizabeth, I'd love to hear from you. Okay, she's saying she meant solar disinfection of water for drinking. Okay, so yes, it's a great strategy. And what I will say, it's an adjunctive strategy, as in you can't rely on that alone because there are impurities in it. So yes, in addition to something, you can use that strategy, but not alone. Okay.
I think we've covered everything. We will definitely share our presentation with this group. Dr. Nanda, if you have anything to add.
I think this was great, and Ochechi, we should, this was a great collaboration, and it's been just wonderful to have this conversation on a Saturday morning here. Very, very interesting and very, very intriguing. Thank you so much for joining us. Ochechi, please, if you have any final comments, please go ahead.
Thank you so much, everyone, for joining in. Thank you, Melin. It's been fun working with you through this process. And thank you, Dr. Nanda. I'm very, very grateful for bringing out your time to teach us everything you just taught us. I really gained a lot. Thank you, everyone, for joining in. I'm really, really, really grateful. At least you didn't leave me out in the rain. Thank you.
All right. Thank you, everybody, for joining. Hopefully, we'll get to do this again in the future.